All right, sweet. All right, I think we're all ready to go. So, Nick, why don't you just introduce yourself and let everyone know like what position you're at and where you're at in like your med journey, like your doctor journey and stuff.
Yeah, sure, sure. Nick Brown's my name. I'm currently in a radiology registrar position at Western Health. Halfway through the second year now. Came through Deakin Uni for med school, and then I've only ever worked at Western actually since I finished. So it's been nice to sort of continue at a place that I guess I enjoy. Being in a slightly more senior role now, it's sort of nice. You see people come up and you recognise people on the phone when they make referrals and that's kind of where things are at now. Radiology is one where you do most of your training at the same site. There's a couple of external rotations and things, but otherwise, it's kind of nice to be settled in the West.
Yeah. No, that's really cool to hear like you've had a bit of like longevity at the same place. You get to recognize like the people like moving up from like potentially med students to interns and now like moving into more senior positions as well as yourself. I guess where did the radiology sort of come into your mind in terms of that being a potential like career option for you?
Yeah, I guess probably something that was always like on the back burner. I guess like prior to doing med school, I was a radiographer, so I guess I've not really ended up too far from that type of line of work. But I don't think I set out when I started med school to sort of do any of that. I guess sort of my journey in a couple of minutes would be I was sort of ready for a new challenge at work when I was doing radiography and doing a reasonable amount of CT and after hours work as well. I was sort of ready for something a bit different. And so I had a chat with my boss about doing ultrasound actually. And he kind of said to me, "Oh, look, I think it'd be good, and it'd be a good challenge for you, and all the rest of it." But he's like, one extra year difference in sort of study, and you could be a doctor. Like, have you ever sort of considered that? And I probably hadn't since I was 18, sort of fresh out of high school. Obviously went and did undergrad in medical imaging. But I was going, oh yeah, okay. And he's like, oh, the exam's in, I don't know, we must have this chat in like November or something. And he was like, oh, look, just have a crack. And he's like, if you find out, let me know how you go. And we can sort of work it out from there. And, sort of like just scrape through, scrape through GAMSAT. And I guess sort of here I am. But the, I guess the path from that was, I had a really good radiologist that we worked with, same guy most days, which a lot of community sites even don't probably have that privilege. And we kind of all knew what Robert wanted for certain things, and he was quite good at. He would sort of match your level of enthusiasm, I guess. If you were to come to work and do your own hours and go home, it wouldn't bother you too much. But if you were keen to sort of learn a little bit more, he'd sort of call you as this grumpy German guy, and he sort of call you in. And I might not quote him, but you get someone into the office, and what the hell's going on here, and he'd sort of talk you through it, and and I guess that sort of we sort of fed off each other quite a bit, and you try to find out a little bit more about the patient than perhaps you will provide on the referral, and I found all that quite motivating, and particularly like because I worked part time as a rad during med school and things, and you start to pick up on more and more stuff, I guess, as you go through, but I still didn't think that radiology would be for me, to be totally honest. But probably came full circle on it. Just I think with I enjoyed surgical problems. I think probably a slightly more acute medicine interested me more. And sort of fix that, and maybe some of the things that are a little bit long standing didn't quite do as much for me. But I think eventually sort of came full circle with like you've got a whole scan of the entire abdomen, and sure, maybe they've got some some enteritis or something, but how much more can you sort of get out from that? And watch guys sit there and then look at the sacroiliac joints guy. There's some sclerosis there. Maybe this is Crohn's, and just picking all of that from the same one snapshot in time. I was like, oh man, this is for me. So landed very close to where I was, but I probably went around full circle to get there, I think.
That's really cool. So did like you worked as a radiographer before you had even started that med school journey, right? And then it was just from that conversations with like the radiologist and everything, and that sort of got you inclined to like embark on that med school journey, right?
Yeah, for sure. I did first like work experience, that you do through high school. I went to a little settle in Caboolture, which is about an hour north of Brisbane. And as a year 11 student, went in a week and just sort of checked out what radiography was all about. I was like, oh, this is kind of cool. It's like it's medical, it's very sciencey, physics. All the stuff I sort of enjoyed at school at the time. And then, I guess I'm fortunate enough to get a scholarship at a uni in Queensland who didn't do med but did who did medical imaging, and that was enough for. I'm not sure how hard I was really considering med at the time, but it was kind of like free degree, like and I knew I'd enjoy it, and I ended up actually working at that same centre I did work experience at when I finished undergrad, or I did a year somewhere else first, but ended up there for sort of 3 years full time before I came down here.
That's awesome. And so just for everyone like listening, how long is the course to do uh like to become a radiographer? Like is it just like 1 or 3 years, or what is the sort of entry requirements to do that?
It was 3 years when I went through, and in Queensland, so it was a different system at the time as well. But I think when I came through, it was a 3 year degree, and we had an OP system up there. It was OP4, which I think was about an ATAR 94, I think loosely. I may be completely wrong on that, but I think that was about it. And 3 years, and then you sort of came out and you had to do a year, a supervised practice program, essentially an internship, that you and I have both done. And that had some limitations, and you had to have however many full-time radiographers with you on shift and things. But I think all of that's changed now, and it's more of a 4 year degree, and you can come out and work sort of wherever, even if it's on your own. Which I think there was a bit of a hold up in getting people jobs at the end of the degree, which was starting to sort of affect our year. Like I think we had 110 of us and only 43 public jobs at the end, and private probably picked up about the same. So unfortunately, there are a few guys that sort of missed out and didn't get to work after doing the degree. So I think that's sort of one of the workarounds, and it sounds like that's sort of happening in Victoria as well. But I think on the whole, it's probably a better way now. But I think it's it's becoming increasingly popular.
Yeah, 100%. Like, I think, like, it would just be such an in-demand service. It's funny to hear that there's, like, not enough jobs to go around. Like, I feel like everyone's always waiting on scans to be done in the public and, like, private sectors. Like, you'd think there's just be like, if you wanna do radiography, just here's jobs and stuff. So, interesting to hear.
Yeah, exactly, and the fact that you can then go and do your MR, or usually it's probably one of the more direct ways to do ultrasound as well was it's sort of do radiography first. But it sounds it seems like there's a bit of a hold up. But it's a very, very clever ads, and to be totally honest, I think I'd be very still happy doing that as a career. At this point, I had a great time.
Yeah, that's awesome. And I mean, I feel like both you guys and pharmacists would have had a massive advantage going into med school. Like, if I could like learn how to do scans and learn about all these medications, I feel like med school would have been a much easier journey. But did you feel like it helped you at all, or gave you like a little bit of a heads up, just having like the radiography as a background?
I think, to be totally honest, I think probably the biggest advantage it gave you was the what does a sick person look like. I think that was probably one of the best things, maybe more so than like you've had a little bit of a look of anatomy or path before. Is it was just seeing someone that looks sick. Like I remember very early on, we had a bloke with a bowel obstruction, and just looking at this guy, and like we're in outpatient land, like most of the time it's sort of more chronic things that you're looking at, I guess. Probably more GP referrals than hospital based stuff. And this guy came in, I was like, holy crap, this guy he just looks terrible. He's 45, and I was pretty young and naive, and took the pictures, and Rob came, sort of called us up, and he's like, where's this bloke? This is just like this has got a bowel obstruction, and we're like, oh man, like and it's funny how like that picture sort of just sits in your head, and it's like that person's not well. I think that helps you quite a lot, and it's people still surprise you, particularly in ED, that are very, very stoic. Or perhaps you're a little bit dismissive based on your first interaction, and they actually it turned out that riddled with it was something you weren't expecting. But I think that was probably the biggest advantage. But yeah, it's funny you say pharmacy because we had a mate who did pharmacy at uni. And yeah, I was very jealous of what she knew, and she was very jealous. The other way around. For me, all the medications and things, I think I would have preferred the leg up with that. But yeah, no, it was good, and I'm not sure for you how much medical imaging sort of made the curriculum. For me, it probably made up less than I thought it was going to, given how sort of increasingly reliant we are on imaging. But then, by the same token, I guess that's why it's its own specialty. So
For sure. I think maybe hopefully they change it to include a bit more medical imaging. There's always a series of lectures at some point that teach you like the physics of like CTs and MRIs and stuff. And then I feel like it would be a nice way to lean into each unit block that you do. So if you have like a cardiology or respiratory unit, tie in a bit more scans to that would be certainly more useful for medical students because I feel like that's the first thing that is that all interns struggle with is how to read scans and what to do and how to order them and all those sorts of things. So yeah, I definitely think more input into the medical school curriculum would be super helpful for everyone.
oh, for sure. And I think, with like, yeah, when you're at that first Met call and you're sort of shaking a little bit and oh, please just let me write the notes. And you go through all those OSCEs going, VBG, vitals, VBG, ABCD, chest X-ray, and it's all well and good rattling all of that off for that. But then when you actually got to do something with those results, right? Like, it's a bit more daunting. So yeah, I think a little bit more rehearsal in those things would be handy. But so at least at Western, we I'd probably get a couple of phone calls a day for can you have a look at this? So that's also what we're there for.
Yeah, I think it's like they're like the two best friends for an intern when you first start the role is like the ward pharmacist and then going down to radiology and making good mates with like the radiology registrar who's like reporting all the scans and just making sure that they can help you get the jobs done that you need to get done for the day. Like it's just so helpful. And so when like because like could you like take us through like the radiology sort of program and how you sort of get into that and how many years you have to do working just in general rotations before you start even thinking about like applying to get onto the program and like how does that sort of all work?
Yeah. It's so like what's written on the Radiology College's website is simply 2 years, 2 years out of your of med school, HMO3 onwards, basically for the start, and uh, an understanding of physics and anatomy. That's not really quantified on their side as to what constitutes that, but that's sort of what they're expecting in your resume, and then an interest in medical imaging. So it's certainly compared to like some of the some mates doing surgery where they've got to get their 30 points in across various areas. It's quite non-specific in a lot of that. So most people are eligible whether they whether they know it or not. But I think in terms of sort of making ground and sort of making a part of it, my background helped. I was fortunate enough to do like a medical imaging rotation early on in internship, which sort of helped you sort of meet a few people. And I guess even as a radio, you probably you kind of know what they do in the office, but you certainly get a much better appreciation, I think, once you're on the other side, as a doctor. But I think things that are probably reasonably common through most of the people I know who I'm working with now, um, they probably have some extra tertiary education in anatomy in particular. Um, to go through. So probably the most popular one is the grad dip of surgical anatomy that Uni Melbourne offer the first half of most years. Um, I think that I can probably think of maybe 4 or 5 people who are on the program who haven't done that. But I think on the whole, it's pretty well respected by various imaging departments, at least across Victoria. Um, I don't think there's anyone saying like, "Oh, you have to do that one," but I think you probably need more than I liked it at med school to sort of really solidify that you're going to know your stuff when you get in, because when you get on the program, your first exam is 3 months in. So rather than getting an entry exam, it's like, oh, congratulations, here you are. You know, please forgive us all your fees, and also you'll have an exam in March. You know, so and the exams are going to be in physics, so it's not so much the pathophysiology. You're not going to get chest X-rays up for image interpretation, but you're going to get a lot of what's that, or describe the course of this, or we've all done that at med school. That's just that's sort of the next level, I guess.
And did you do the dip and nat at Melbourne Uni?
Yeah, I did that in my HO2 year, um, and it is a great course. I probably for the, like it is it's worth about 20 grand, which is a pretty big hit, I guess. When when you're only essentially 1 year out of with savings or whatever. I guess you can put it on the some fee help or hex equivalent, whatever it's called, and then sort of pay it back later. But I think the guys who probably got the most out of it were ones that were were either locuming and maybe only working 2 or 3 days a week, and they were able to go to this course because it ran 3 times. 3 times a week, at least when I did it. And me being on ED and nights, I think during that set, meant there were a couple of times it would just be like a whole week we couldn't go. But yeah, the guys that were probably working a little bit less, I think, got very good value out of it. And once you have a cadaver where you've got dissections for your chosen specialty. So even if you're not radiology keen, most of us did the neuroanatomy. That was deemed probably the most appropriate for that. But if you're urology keen or you're ortho keen, like you do a shoulder and a leg as your dissections, whereas we were doing face and brain. And there weren't really any specialties I think that were spared from that. Which is really cool. And if you got through your dissections and you were happy and comfortable with the rest of the course, then you could say to them, I would really love to sort of look at the lumbar plexus in more detail, and they'd be like, all right, cool. And if your specimen still had a lumbar plexus that hadn't been gotten to, then you could go and do that. And so there are a couple of guys who did probably 3 or 4 extra dissections during that time. And again, these anatomy tutors and things would just sort of meet you at your level. If you could get there all the time and you knew your stuff, then you could just keep going. So
That's absolutely fascinating because I know we get exposed to it at med school. We do a bit of dissection. I think like you guys did it as well at Deakin as well. You got some.
yeah, mostly models. But I think is it Chris Briggs? Is he the anatomy master from Uni Melbourne? I might have his surname.
Or it was at my time it was like Jenny Hayes. She was like in charge of all that sort of stuff, but potentially Briggs as well. I'm not sure. The name doesn't ring a bell.
He'll have to forgive me if I'm getting his name wrong, but I think he's semi-retired towards Torquay, which sort of made him recently cross close proximity to Deakin. And I think he made a big influence, even though he was probably only working a day a fortnight with the team. But yeah, we had a good set of tutors, but that was through your non-clinical years, so you'd obviously everyone had at least 2 years off from doing any of that. But there were no. Maybe there were some skulls just to show the foramen a little bit more consistently than a real one, but otherwise there was no plastic in that tube room. It was all there was 60 cadavers, and that's what you learnt on for the 4 months.
Yeah, that's super exciting. How does one go about getting into the program and like how long does it sort of last for if there was, people listening who want to sort of get involved or potentially try to do something like that? And is there like other courses in different states that offer a similar sort of anatomy like program if someone wanted to get into like radiology or something like that?
The only other course I know for sure that runs is one through QUT. Through Queensland University of Technology in Brisbane, and it's an online course, so there's no dissection element to it, and I don't think there's actually an exam for it either. So it's kind of I wouldn't say pay to win, but like it's you pay your 5,000 or whatever it is, and you're provided with the lectures, and you sort of learn from that. But the hands-on experience and sort of keeping you honest, I don't think you get that from that. I'd imagine that there's probably one in each state that would be of at least that caliber, similar. And obviously not everyone in the country on the radiology program is doing the Uni Melbourne course. So yeah, there must be plenty more around. But that's the only other one I know of. But yeah, in terms of that, the physics interest is the other thing you sort of have to show that you're satisfied. I think most people do a course through Westmead. One of the hospitals in Sydney, they have a physics thing, and that's only about $1,000 in contrast to this other one. And it's again a series of lectures that you can sort of do at your own pace, and then I think for your $1,000 you get 3 cracks at a practice exam, which is very similar to the real one. I think the I won't lie, the material is dry. Some of this stuff, and it's not all things that you're thinking about on a day-to-day basis. In my job, it's written by physicists, and they're very, very clever. And don't get me wrong, but I think that's quite similar level. To what you sort of end up with. And the college do, once you're on, you can enroll in, some additional things to sort of help you get up to speed with those things. But I'd very much encourage that you probably know your stuff before that. Like the offers, I think, came out last week for the new cohort of first years. And I'd probably encourage they start at least with the anatomy, celebrate maybe this month, but then probably get stuck into it because if you want to feel comfortable going into the exam, I think you probably need to start pretty close to now.
Yeah, yeah. And, like, how did you sort of manage, like, doing that sort of dip and that while you were I mean, I know you had, like, nights and EDs a little bit more, free for time to actually go to the, cadaver lab and dissect and learn everything. But, I mean, it's pretty tricky sometimes to, think about all this stuff called programs while you're doing a full-time job. I don't know, like, how you found it and stuff like that.
Yeah, for sure. And when you've got to anticipate that 6 months earlier because you're choosing your rotations or whatever for later on. So I guess there's always people who you might be able to swap with if you sort of decide that you want to have a look at this a bit later. But I think I'd deliberately put at least ED as my first one because I figured there'd be the odd time where you'd have maybe 4 or 5 days off in a row, and that would hopefully land on the days where this was on. I think I went in once before nights because you sort of start at 11 and this thing had run from 7 to 10. I only did that once. That was a bit much, but there were plenty of other people more disciplined than me that gave that a good go. I guess you kind of just got to make it work. Keep your eyes on the prize. And sort of just find a way. But I don't know how I would have done that if I was on trauma at RMH. Through that where your shifts are sort of starting at 10 hours minimum. I'd take my hats off to guys that were doing that type of thing during that.
For sure. But apart from the anatomy course, you do that, like, little diploma, then you do this physics course and work for 2 years, and then from PGY 3, you can essentially apply if you, have, like, some references. Like, do you need to have even got a radiology rotation? Or, I imagine you would have, like, had to have references from like the radiology department or something.
Yeah, I think all of those things help, and if you're able to sort of get involved with like an audit or research, I can't say for sure, but I think if you want a job at RMH, you probably need research at RMH and probably something that's publishable. I think for some of the slightly more peripheral places, involvement in an audit or something may not need to necessarily be written on paper to or published to sort of get in there. But I think each department's going to have their own weighting as to research. While it's not technically one of the 3 criteria on the website, I think that those things are probably going to become more and more important as everyone sort of has similar appearing resumes, and the quality of candidates I think is always getting better. So I think if you can sort of make your way in at wherever you're working, and at least say good day and sort of meet people, and then you might be able to come up with there will inevitably be some sort of audit going on, whether it's just biopsy quality from from what we're doing down there, and what's our hit rate with thyroids or what have you. like someone will be doing something in some capacity, particularly the IR guys. They're quite quite happy to I think there's two or three things going on at Western at the moment where they're um, uh, they've either changed the way that they do a particular procedure, or there's a new device now. It's like coming the time to compare that to what we used to do. So I think most places would probably have something loosely along those lines. In terms of getting a radiologist reference, I think unless you've done the department rotation, that's probably maybe not appropriate. Like as much as you think it's probably going to be super helpful. Like if they're not someone that's actually done 13 weeks with you on the ward, how much can they know about your work ethic and all that type of thing. I think if you're in pretty deep, then sure, it probably can't hurt. But when you only get to pick three for your, or two for your, no, sorry, no, it would be three for your application. I guess you got to make sure that the people who are going to be able to best recite, and be representative of you as a person are probably those people to pick. So
But that's interesting. So you don't actually need like a radiologist for a reference to get onto like the radiology program. Like if you were, you had a few good rotations in like say surgery or, in like one of the medical rotations, like they would be good enough references if you got on with them well enough and they, respected your work ethic, etc. They would be like a good spokesperson for you. That would be good enough for reference.
yeah, for sure. I'd be surprised if everyone who has gotten on in the last couple of years has had a department reference. I did ask for one, given that I did the rotation there. But I think, to be honest, I think it was the other ones that probably were contacted, particularly at Western, because they knew this person directly, and it probably wasn't a formal phone call, and I probably didn't know that particular person any better than the directors or better than some of the other consultants that were, that I'd worked with during that sort of 10-week stint. So, whereas, yeah, I think if you, I would pick the people that you, that know your work ethic. Maybe one of those three could be slightly less clinical if you've done some pretty deep research. But then by the same token, you're going to have their name probably on your resume. I've done research with X, pretty proudly on the thing, and they're not going to go, well, it's not one of the three references. We're not going to try and verify that. Like, I just don't believe that that's how that goes.
No, that's cool. And is there like a limit to how many times you can apply for the radiology program? Like some specialties have like a three shots and then no more sort of policy.
So that's again like actively changing. So I think from next year, you're going to have. So when I came through, you applied directly to the health service, and most states sort of had a match system similar to like we do, through PMCB. But so if you wanted to apply for the PA in Brisbane, then you had to apply through the Brisbane match, and that was all separate. Radiology, I think from this year coming, will have a central process for the entire state. For the entire country, and I think that that's probably to combat a little bit of people waiting for a second offer and then jobs coming up, and then this late swapping and all the extra stress and probably money that's getting burnt on that from various health services. So, and I think that with that will come almost certainly three or four limit. But I think that the compromise to that was that you only apply once. So you do like your application fee and everything, and then that buys you the match for 3 years or four attempts or however many that they're going to do. So you won't go through PMCV as of next year. It'll be through Ranscar's like internal match.
That's interesting that it was like health service specific to get onto a training program for a specialty. Because like usually like they just have the applications through like their specific colleges or whatever it is. But I mean, if you wanted, because now you're at Western Health, doing radiology, if you wanted to move health services, is that a possibility, or are you like tied with that health service for a few years now?
Like they are technically annual contracts, but the amount of moving around that happens is quite limited. Although that being said, we had someone who came from Geelong last year and has joined us at Western for this year as a second year. But I think historically that doesn't happen very often.
Are you able to move at all? Like after like 4 years or 5 years or whatever it is?
I think the job would have to become available for you to apply for it. I don't think I could go like knock on the Alfred's door and say, what do you reckon? You got an extra 30 spot next year or what have you. I don't think that really happens to the best of my knowledge. I know there was a fifth year job that came up for last year because someone you can start a nuke med fellowship in your fifth year in most states, and I think someone jumped into state to sort of get on with that a bit earlier, which created a path for a fifth year, which then probably so there probably was a little bit more filling that goes on with that. But again, I don't think happens very often. Like each health service kind of have like their rural place that they're associated with, and so for your rural placement you go there, and it all sounds like it's pretty well organised. And if you don't have women's imaging exposure where you are, then you'll have external rotations to sort of facilitate the gaps in that type of thing. And it sounds like it's all reasonably robust. I think maybe 4 or 5 years ago there was a little bit of sort of trading where, like I think some of the guys who are like now junior consultants went and did 6 months at the Alfred, and someone from the Alfred came and sort of filled in for them at Western for a little bit. But I think that's pretty much done now. I don't know really why. I don't think it's a good idea. I'd love to go and probably see a little bit more neuro or trauma than what we see at the West. I don't know what we can offer in exchange. Maybe maybe with JK and some of the paid stuff, we've probably got a little bit more of that.
Because I mean, like, there's different, jobs. I know in like surgical jobs, I mean, you're pretty much rotating each health service, and I think it's only a benefit, albeit you have to get used to a new system and learn the intricacies of that. But I mean, that's sort of like part and parcel of the job. I think you're exposed to different patient populations and different health services. It's going to naturally make you a better clinician. It's weird that you're sort of just stuck in the one place, right? I don't know if you sort of have any thoughts of to like what you would prefer, you know?
Yeah, I think stack might be a bit harsh. Like I'm quite happy where I am, but yeah, I think I probably would like some more exposure. But I think, to be honest, I think in your first couple of years, there's so much that's new. Like you're not short on work. There's plenty of new things, and like we're busy enough that you can if you've seen a few things, if there's 10 on the list to report and there's something, reasonably simple appendix or whatever, you can kindly nominate to one of the first years who might get a little bit more learning benefit and pick something else if you really wanted to. So, and outpatient work, like there's plenty of that. So if you've got a particular interest in something, there'll be 15 of those particular scans on the outpatient list that you can, if you want to make the time for, you can go on with. But yeah, I think I probably would like, we find brain tumors on accident. You never see any of the follow up imaging. You don't really see a whole lot of imaging follow up for trauma other than like the slow subdurals that are probably still stable enough to stay under gen med. So, those type of things are probably of more interest to me. And I think that you would probably get more of that at places like RMH Alfred. But again, then you're going to lose. You're always going to be trading off with something. So I think here at the West we build pretty robust generalists. I think we see most things often enough. A lot of TB. I'd be surprised if there's anywhere seeing more of that in the country, or if it certainly feels like that when we're looking. But I think wherever you want to pick something, you've probably got to backfill it. And I think until you get into like a fellowship stage, maybe it might not. If you don't have a dedicated gynae unit, you probably can't offer a pelvic, or women's imaging, fellowship in that department. But I think you're sort of until that point, it's enough for most things.
For sure, for sure. So, like, currently you're a second year radiology reg, correct?
Yeah, second year.
Yeah. So what's a like a normal sort of like week in your life look like in terms of different days and different responsibilities like in radiology? Because there's different parts to the job. It's not like you rock up to the same ward, do the ward round. Like it's a different sort of style of work, right?
Yeah, it is, and we've like at our department, we've sort of all changed this just recently, actually, sort of effective this year. So we'll usually have the same role for a week. Whereas before we were sort of doing, like morning you might be MRI, and then the afternoon you might be CT, or or you might be the person on the phone. Which is depending on how many calls you get, is greatly impacts how much reporting you'll get done. Whereas now, yeah, we'll sort of have the same procedure team, so there'll be two regs and a consultant looking after all the ultrasound reporting and all the procedures. We'll have maybe a couple of guys on MR. One of them might be doing a subspecialty rotation in that, so they'll just pick up, they might pick up all the MSK, and if you're the other red chip, you sort of go through what you need to, and then you'll have ideally 4 people doing CT. That's very variable. That's kind of the first. If someone's sick, that's probably the first role that gets pulled from. And then, yeah, we'll have a couple of guys on the evening shift, which is, sort of like your covers on the ward, I guess. Whatever's left on the list, you're sort of just triaging as that's the most important scan, or that looks like there's the most going on, or maybe this, staging oncology thing is really, really, like is going to take a lot of time. Is that worth me putting 45 minutes an hour into reporting that one person, or do I just keep up with all the acute stuff? So you sort of got a fair bit of internal triaging that you do when you're looking at these things, and then one lucky person on nights for the week as well.
Got you. But it's good that you get like a bit of procedural exposure as well, like mainly with like ultrasound or potentially even like CT guided stuff as well. Do you guys ever like cross paths with like the IR people too, or you sort of just let them do their thing?
Yeah, so I guess for most people, if you're not in and about radiology all the time, there's diagnostic radiologists still do a lot of procedures. So MSK injections, acidic taps, pleural taps, even deep drainages for a previous appendiceal perf, and you've got a big abscess sort of around that. That's sort of most of that is in diagnostic territory, to be honest. Anything endovascular, maybe like a PIC line, is sort of heading IR's way in splenic embolizations and these things. So I'm going to list it. Probably going to sound terribly surprising. TIPS procedures and all that sort of juicy stuff is all IR. Occasionally there'll be a little bit of double up if they're suites free and maybe they don't have a whole lot of acute things on the list for whatever reason. They might pick up some of the stuff that is technically diagnostic, but I guess if you've got someone who is doing that type of stuff even more routinely, they might pick those things up and let us get through some more of the simple stuff. But yeah, some of the guys in like their 4th and 5th year will go and do like a dedicated 6 or 8 weeks. It's almost like a trial fellowship in sort of deciding what they like. Once you passed all of your exams and things, you can look at doing those. But otherwise, yeah, procedures. You do a fair bit. I think particularly at Western, we seem to do a lot. Um, yeah, and they're good fun. They're immediately gratifying most of the time. That nerve roots, they tend to get a bit of exacerbation of pain. You're like, oh, was that where you got your pain? And then you feel pretty good, or you get that little bit of gunky stuff from whatever's exploded that wasn't meant to, and like you're in, you've got it, and you can send it off and sort of go from there. So there's a fair bit of coordinating and organising that goes with that job as well. But it is good fun. I think having that sort of to break up all of the diagnostic stuff, like I think one of the reasons I wasn't super keen on this type of job when I maybe first started med school was that I didn't really see myself sitting at a computer 7.5 hours, a day without really doing anything else. But these kind of break up the day quite nicely.
I think that's a good, a good learning point or consideration for people who maybe are leaning towards radiology, maybe not. It's not just sitting in a dark room, just reading scans and writing notes on a computer. Like you do actually get some level of patient interaction, and potentially you can even lean more into procedural if you want do more like interventional radiology and stuff like that. Like it's not just sit in a corner, lights off, everything like that.
Oh yeah, for sure. And for people who do enjoy that type of thing, they can do that as well. You sort of see that as I guess newer bosses come to you. You realize what type of things they like, because some of them may not ever be on a procedure shift, and others seem to like it. And I guess that's probably they probably get a bit of opportunity to sort of have a bit more impact on the regs because they're physically in the room with you as well, rather than just sort of cracking through all of the outpatient stuff. But yeah, there's no shortage, no matter which side of that interventional fence you want to be on.
For sure. So, how does the rest of the program look now? I mean, is it like a 4 or 5 year sort of reg program, and then you may do a fellowship if you need to, and then you become a consultant after you pass all your fellowship exams, or what's the sort of roadmap look like?
So that first exam very early on. So there's two big exams through the program. There's the one very early, and then you're eligible to sort of sit the other one and start a fourth year. I think you can. Again, this is just all very dynamic. I think you can technically sit your path exam from third year. Like I think our year might be the first year that can do that. Um, but you also need to know all that path knowledge for for the real the Viber type thing where someone will just show you cases and you've just got to either pick it straight away or answer various questions about it in a sort of Viber style thing. I think there's a report writing exam too, which I guess is more of a sit down for 20 minutes, look at the case yourself without that pressure of someone sitting right behind you. But yeah, those things are mostly sort of start a fourth year, and you get four cracks at all of those. Which for a 5 year program, the exam runs twice a year. So I guess maybe the initial theory was if you start at first or fourth year, maybe it takes you 2 goes, and then you've passed it by fifth year and you can go. But I guess that absolute worst case, if you're using your fourth go, you'll still finish the program on time, like in that 5 year window. Fellowship, like not compulsory by any stretch. There's plenty of plenty, particularly in private, where you can work without necessarily having a sort of subspecialty. I think probably to stay in a public job, I think I think by the time I get through, it's almost going to be essential. Unless you're someone who's already got 25 years who just never did a fellowship, but all you do is MSK and you've got that experience to back you up. I think that's probably the way that's heading. But you can also do as many of those as you want if you want to go and do body and breast, and they're the two things that you really enjoy, or you want to do gynae and some nukes on the side, then like that, you can, if you apply the fellowship, you can do that. So um, 5 years registrar, and I think there's a bit of flexibility in how full time you are as a fellow as well. If you might only get a 2 day a week public job, and so do you want to go and work another 2 or 3 in private land? And you might be a consultant on Wednesdays, but then on Tuesdays you've got to talk to someone else about your findings. So it seems to be the way it goes. But yeah, in brief, it's basically get through that first exam. Second, then just see as much as you can, and then I think when you're probably 18 months away from that fourth year one, you're really got to sort of settle down. I'm not that clever. I probably need 2 years. But I think that it's all about building to that, and then just once you pass that, and you don't have to rely about the itty gritty fine details. It's again building on those skills of lesion detection and then ability to interpret that with the history.
Yeah. No, man, I reckon you'll pass it first time. I've worked with you. You are a very smart cookie. What if someone like started doing like radiology and they're like, oh, like I mean it's cool, but I want to go into more interventional radiology territory. Is that a separate thing you do after you complete all your radiology fellowship exams, or do you just pivot whenever you want?
So it's like fellowship time. So all interventional radiologists are diagnostic radiologists, and then I've done a fellowship in interventional radiology, which is a two year gig. I think nukes might be 2 years as well, but you can start it in your fifth registrar year, so it's effectively still only an extra year on the whole thing. But otherwise most fellowships would be 12 months. IR's 2. probably reasonably self-explanatory as to why. Yeah, the thing that is slightly different is kind of loosely in our realm is like radiation oncology, but it's its own pathway. It's all part of the same college, but it's not like there's no overlap. We don't go and do a term with them, and they don't come and do diagnostics with us or anything. Yeah, it's separate. And nuclear medicine, there's a couple of ways you can get in. So you can do radiography. You can do radiology and then do a fellowship in nuke med, or you can be a physician and come and do some nuke med training.
Yeah, that's interesting. I think it's a good like specialty to go into in terms of how, like it doesn't take like 6 or 7 years of doing unaccredited regging or all that sort of stuff to get accepted onto the program. Well, yeah, one person in my year got in, PGY2, like, they applied and they knew that they were going to do radiology regging in at the start of PGY3. I mean, that's like super cool and reassuring so that you're not spending years of like research and, unaccredited regging or whatever it is to try to get your points up to get onto the program.
Yeah, it is nice like that, and yeah, I certainly have sympathy, particularly for like the BBT guys who, there's this big fight to sort of seemingly get to just that part, and then there seems to be this other gateway at the transition to an advanced trainee thing. Yeah, so yeah, fortunately, radiology doesn't seem to have that yet, and but I think the unaccredited role is probably slowly going to creep in, much like it has in the sort of most of the surgical specialties now. I think inevitably that's probably going to happen. Yeah, whether that's good or not, I don't know.
Yeah, hard to say. I mean, it's just if it becomes competitive and there's just like an oversupply, then they have to, increase like the bottleneck, and then by nature it increases the competitiveness. And
Yeah, exactly. And like for an employer, it's kind of a 12-month look. I guess particularly while it's you're at that one particular site, it's a 12-month job interview essentially. I guess.
yeah, Nick, I reckon you've come across a fair few struggling interns trying to protocol a scan, or junior doctors who don't really not well versed in the radiology sphere. Do you reckon you'd have any tips for like any junior doctors or first time players just navigating the radiology space? Any like tips or tricks to make their life a bit easier?
Um, yeah, yeah. There's a couple of things I think help. One easy sell to us is if we've recommended something. That's usually if you got that, lead with it. That's if we've seen something on ultrasound. It's usually pretty. That we'll be interested in it and want to know, and so feel free to recite our report back to us. That's fine. That's obviously not always the case, but I think probably the big one for me is like yeah, it's difficult when someone says, oh, just get a scan, and regardless of maybe you haven't seen the patient, maybe on one of those horrible cover shifts, and it's like, oh, this person needs a CT. You do have to know why, because the way that we may obtain those pictures or extra imaging we might need to go looking for, like if your question's really perianal abscess and sort of just written like non-specific abdominal pain, and the guys don't scan low enough for me to see that spot, then we won't be able to comment on it. And then, it's then 4 hours later, we'll get a phone call. Oh, you didn't mention perianal abscess. Can you have another look? Which is that, like, sure, that's never a problem. But then we'll go, oh, we're not really covered that area, and yet we've probably scanned, the lung bases, which you weren't interested at all in. So, like getting that right is quite handy. And then, if we see that we've not gone long enough or not gone high enough, we can sort of get that range in. Sometimes it's a different phase of contrast that we need to identify what you're looking for. I think that's, if you write things like, oh, it needs diffusion restriction imaging on MRI, please don't write that. Please write what you're actually looking for, rather than the sequence, because we need to do it in the right spot as well. And sometimes I think there's a little bit of fear, like, oh, radiology won't do this arterial phase thing for this, but it's like, well, if you tell us that, like, you're worried about a pseudoaneurysm as a complication of the pancreatitis, we won't forget to do that. So sometimes that question is masked, and I think sometimes we don't always know why those things at like the ward level, the boss is just, oh no, all my patients get this because I've, a couple of them been missed, and that's what it is. It is really helpful to try and nut out what that is. But I think the bigger thing overall is, please don't let the history be deceptive on the request form. If you don't know, it's okay. You can write your leading diagnosis and then your objective things, like that's all fine. But don't write something like, "Oh, ultrasound equivocal for stones," or "previous ultrasound had stones," if like outright didn't, because I'll spend 20 minutes looking for them. Or like, and it's okay. Like if you've got a leading clinical question, you think that's what it is, like lead with that. That's okay. But be objective with your clinical examination findings and that type of stuff. Like we're here to help, and we're here to offer the best or most appropriate imaging that's available based on your scenario. And you don't always have to have decided what you think the best test is before you call. Like ring up and go, "Hey, we've got this young patient, a bit radiation conscious, and that's got this lower pelvic, almost pelvic pain." And we can go through the relative positives and negatives as to whether does it sound gynae or does it sound like a CT-able offence in the first instance, to sort of help you with that. So we're here to discuss those things and sort of help guide imaging as much as help you interpret the imaging.
Yeah, I 100% agree. That's excellent advice. I mean, there's lots of conversations I've had with radiologists who literally tell me what scan would be better to do, or walk me through like my clinical decision making. I mean, the wealth of knowledge that they have is like, excellent. And I think if you just ring up a radiologist and ask for whatever the reg asks for, or a CT scan, and you don't know anything, I mean, just clarify everything, and then the more information you supply to the radiology department, the better result is going to be fed back to you, because otherwise it's just like you guys don't know what we're thinking or what we want.
Oh, for sure, and I think particularly when, like, if maybe on the ward and you've seen something before we have, for particularly with plain film, I think that happens quite often. Is the ward registers have seen it well before we do. The best imaging someone's had is one that's already been done, and prior imaging is far more important than new imaging that you want to order. And so sometimes when they've got this chest mass or something, and you can go back, "Oh, actually it's been there since 2019," or, "Oh, I think they've got an aortic dissection." Well, actually it's really ectatic, and I can prove that it looks like that because it's been there for 4 or 5 years. I don't have like, that's our domain. That's what we're here for. The radiology archive sometimes has very helpful history that may not even be in the patient's chart sometimes, that just comes out, whether it's in the picture or whether it's even just in the provided history on an old referral. Don't expect everyone to go through trawling through that for every single admission. Like, I don't come across like that. But yeah, if you've got imaging that's already got a report, the report may have the answer, but more importantly, if the old imaging has something and it has a very similar appearance and we can say something stable, particularly overnight, it's quite handy. So but again, that's what we're there for.
Honestly, I think some of the best like learning has come from me actually asking radiologists what they reckon I of certain things that I think I see, or like it's interesting. Like I'll be like, oh, I thought that was that, and then you actually just ask them like, but isn't that white spot or whatever, that couldn't that be this? And they're like, oh, it does look like that, but it's similar to A, B, and C. I don't know, like if you come across many people like wanting to clarify, what they think they see. But I think that's a really good way of learning.
For sure, and I try to be quite conscious of that in my report, like particularly when we may have seen. I'm trying to think of a reasonably common example. Arachnoid granulations are probably a good one in the brain, where there's little projections that sort of help CSF disperse back into the venostrial sinuses, and you see them all the time, and you see them all the time on non-con brains. You see them more commonly on a post-con brain, but then as soon as you see them on the venogram and someone's asking about venostrial sinus thrombosis, it panics because people are looking at the venostrial sinuses and they'll go, "Oh crap, it's thrombus." Radiology missed it, or it wasn't on the report, whatever. We get a phone call. So sometimes I'll write something like prominent to tell you that I've seen it and like it's okay, but I may not write it on every single report because it is sort of common enough that it can be just quite dismissive. So we'll never take offence in, can you help work out what this is, or whatever. And radiology is probably not always the most personable, specialty, I guess. But I quite enjoy when like a team comes down. So some of the surgeons will do that here, particularly at Sunshine. To sort of go through something, and it may be with the surgeon themselves, and then the whole group come down, but you can have a discussion. For us, you're likely to get more of the history, which I quite like. But yeah, and it's good to sort of go through in. We have a bit of our own language in the way we describe things. Like I think when it's a one-step process, like, that is that, and it's diagnostic of that, and that's it. That's all it can be. They're very satisfying, and they're always good. But yeah, when you actually have to put it in the language and then go, well, does how I've just described that actually match with what I think it is or what I thought it was initially? And sometimes you'll go, oh, that actually wasn't that, and there's these extra features, and it's only when you go looking for those that you can sort of differentiate the two. And yeah, it is great discussing those things with with people, and we're here to help. We don't want to make you heroes on the ward, dismissing chronic pulmonary emboli or anything, but it's good to sort of talk about why those things, or why we get particularly excited about some things that look quite subtle, and other when things look quite dramatic, and we can be dismissive is not the right word, but confident that it may not be as acute as perhaps other people think. Those conversations are great.
Do you have any like go-to resources for like junior doctors or medical students wanting to get better at radiology? I mean, the only one that I've sort of come across that's pretty helpful is Radiopedia. I don't know if you have any thoughts on that or others as well.
Yeah, like Radiopedia, very supportive of like Australian made, by Frank Gaillard. And I think Radiopedia is great. The only things to be wary of, I think, when you're getting sort of perhaps a more advanced level, like they've got some wonderful resources for just common MSK things, and I think for general sort of ED things, a 12-month subscription of their program. They go through some reasonably detailed stuff in a way that is quite manageable and easy to digest. I think if you're into like a lecture type series rather than a textbook, I think they are very, very good. Outside of that, there's a few. I'm just trying to think of the UK one. A Radiology Masterclass is quite good. It'll show you a picture, and then when you put your mouse on it, it'll kind of highlight in various colours or try and exaggerate something for you. That's free. I think their chest stuff at least is free. I haven't looked at their paid content, but they on the whole are quite good as well, and it's pretty succinct. I think sometimes you do need someone to go through some of the physics, because I think you need to understand that to sort of take you to the next, rather than just this is that, this is that, this is that. If you want to go a little bit further than that, I think you do need to know how some of the machinery works and why certain pathologies look the way they do. There's no. I'm trying to think of. There's one Craig, one of the other Radiopedia guys, put out recently, which is a reasonably cheap book, which is sort of aimed at that. Maybe end of med school junior guys as a bit of as a ward text. But I don't want to recommend it just because I haven't read it, but I'm sure it's great.
What is that one called? I think I just missed that.
I might have to Google or send you a message. I can't. Craig Hacking is one of the authors. But I can't think of what it's called.
Easy. I'll find it. I'll find it out later. I guess we should probably wrap things up, Nick. But like, I guess if there was someone out there, like a junior doctor or medical student or someone like that, who thought that radiology might be for them and they want to just go all in and try to get onto the program, what's their best bet if let's say they're halfway through internship, they're doing their intern year now, what would be their best bet to try to have the best chance of getting onto the radiology program?
Yeah, look, I think put yourself out there, come and have a chat. With someone in the department. If you can talk to the directors, great. They're very busy. It's easy to say just go and do this, but like I appreciate it is quite difficult. The other thing I'd probably say is like as much as you want to get on early, you want to like secure feel secure in your future and all the rest of it. All of that ward experience like means a hell of a lot, and we've got like there'll be guys where they've been in T Reg for a little while, and so like they'll people at the same level who go, oh, I wonder what Rachel thinks about this, or I wonder what James thinks about this, or based on their various backgrounds. And so you are only going to make yourself stronger by doing those sort of extra ward rotations, be it medical, be it surgical. Maybe derm has less crossover than most, but like otherwise, you're like those things will certainly help. But yeah, come and say hello. We obviously in our department, we're not going to have a whole lot of, other than your referral time, it's going to be very brief on the phone. You're going to be talking to me, who is not going to have any influence on the hiring and firing of anyone in the next couple of years. So yeah, I'd come down, try and find someone, meet someone. Once you've done that, maybe if you can do a little bit of research, it sort of gives you a bit of an excuse to be around or in the department. If your department lets you make referrals in person, I would argue that it's probably not a bad way to do them anyway if you've got the time and the ability, and it's smiled upon. I know not everyone likes that; they just want to sort of pick up the phone, be done, and whatever. But I think if you've got the ability to do that, particularly for more complex stuff, I think there is value in it. But it's also, again, putting a bit of a face to a name from that perspective, I think is helpful.
Yeah, that's really interesting to hear. Yeah, thanks so much for having a chat. It's been like super informative for me, and hopefully some other people listening, if they want to get onto radiology. I think it's definitely an attractive specialty. I mean, like short interval to try to get on, and then some really cool stuff you guys get exposed to. So yeah, thanks very much for having a chat.
A good generalist, especially, I think is probably the big thing for me. Is most things about most things was probably the big deal.
Awesome. All right, so that's the end of that conversation. If you want to be part of something like this, you think you have an interesting story in medicine to share, maybe it's how you got in, and maybe it's that you got on a different training program or you went through some adversity, that's something that you think you'd be interested in doing, then send me a message. The link will be in the description, how you can get in touch. If you know someone else that's probably keen to share their story, or you think that they would be a great person to share on this, then definitely link them in and we can get them on. If you want to stick around, there's plenty of other videos on here to check out and keep you informed, keep you interested, and keep you learning more about medicine. So there you go. Otherwise, we'll see you next time. Bye.